Hello everyone, and welcome back again to the Mycetoma Research Club. We wish you a happy new year, and we hope that this year brings you prosperity, growth, and success. On today's session, we're having Professor David Denning from the University of Manchester, and Professor David is a professor of infectious diseases, and he will be talking to us today about the challenges of long-term oral therapy in fungal diseases by taking the case of chronic pulmonary and allergic aspergillosis. Professor Fahal, now the floor is yours.
Thank you very much, Samira. Once again, I would like to express my sincere thanks and gratitude to Professor David Denny to give us this overview of an important topic, and that is the antifungal treatment. Professor David, he is an expert, scientist, administrator, innovator, thinker, and he is really a great asset to the area of fungal infection. I knew Professor David quite a long time ago. All the time, he was coming with new ideas, new suggestions to improve the quality of the life of patients affected with fungal infection. He was the president of Gavi, and Gavi it is an international initiative looking after patients with fungal infections, putting solutions and innovation in new methods and techniques to improve the quality of the life of fungal infections. Professor Denny, I'm very glad and very honored to have you this afternoon in the Mycetoma Research Club. I'm looking forward for further collaboration and ideas to improve the patients of mycetoma quality of life. Thank you very much, Professor David.
Professor David, you're muted.
Sorry, here we are. I'm going to, it's a pleasure to be with you today. And I'm going to overview today aspects of chronic and allergic aspergillosis in a little detail and focus really on the oral therapies that we give for those patients, particularly itraconazole. So the aspergillus is a very unusual organism. It's airborne, we breathe it in every day, and we don't even notice it. But if you have leukemia or late-stage HIV infection or have had a transplant, then you can get invasive aspergillosis or IA. So that's related to immune dysfunction. And if you have asthma or allergic sinusitis, then you can get ABPA or SAFs, which are exacerbations of asthma and really difficult to treat some forms of asthma, and also sinusitis as well. Sorry, that went too fast. And then you have a number of infections which affect people with normal host status. So keratitis related to injury to the front of the eye. Fusarium is more common, but Aspergillus flavus is pretty common. Aspergillus bronchitis related to bronchiectasis. Chronic pulmonary aspergillosis, which is the primary focus today. Also, Aspergillus niger causes otitis externa, which is common, and onychomycosis, particularly of the toenails, is also caused by Aspergillus in maybe 3% or so of cases, particularly people with diabetes. So this range of opportunistic infection in normal people, but with some other defect, and allergic disease is unique amongst microbes. There's nothing else that has this range of infection. So some years ago, colleagues and I estimated how many patients might be dying from significant fungal infection, and the estimate was around 1.6 million people. And that compares with a number of other infections, which the WHO estimates, this is a few years later in 2019, but about 55 million people die across the world every year. Ischemic heart disease and stroke are the two biggest causes of that. And then you have COPD at 6%, pneumonia at about 5%, and TB at about 2.2%, about 1.2 million. So where does fungal disease fit within that? So recently I've had another go estimating how many patients there may be with severe fungal disease across the world. And probably there are about 6.5 million new cases each year, probably about 3.8 million deaths, of which about 2.5 million are attributable to the fungal infection. So some people with late-stage leukemia die really of the leukemia, and they may have Candida or aspergillosis infection as well. And so that is a death that's not really attributable so much to the fungus, but more to the underlying disease. But you can see that about 2/3 of patients who die of a fungal infection probably have, it's directly related to the fungal infection itself. And this was not possible, would have not been possible, these estimates, without all the ambassador network of Gavi, which many of the members are shown here. And this group and I have worked out how many fungal infections are in all these different countries, and also worked on other aspects of significant fungal infection. So when you go back to that paper and you break down the 6.5 million annual incidence, you can see that invasive aspergillosis is probably the top player at about 2 million, invasive Candida infection and Candida bloodstream infection about 1.5, chronic pulmonary aspergillosis about 1.8 million, and then the other infections such as cryptococcal meningitis, mucormycosis, histoplasmosis, coccidioidomycosis are about another 1 million. So this is the broad group, and then you can also see the mortality or estimated mortality, which is a combination of treated patients and patients in whom the diagnosis is missed and therefore are not treated. And for chronic pulmonary aspergillosis, globally probably around 340,000 deaths a year. So it's numerically a lot of people. We did a very specific piece of modeling of this disease, chronic pulmonary disease, in India. As you know, India's got a population of about 1.4 million, and about 2 million patients are diagnosed with pulmonary TB in India every year. And about a quarter of those patients die. Not all of the patients are correctly diagnosed with TB. So when you see in the table that there's a misdiagnosis of TB, probably based on other data of around 200,000, so 10% are misdiagnoses, and they've actually got chronic pulmonary aspergillosis. And then you develop chronic pulmonary aspergillosis during the treatment for TB because of cavitation, or in the few weeks or months after you've completed treatment, and that's probably about another 150 million. So the new incidence is probably about 360,000 new patients in India with CPA. And because these patients it's a chronic disease, because they don't die immediately, that gives you a prevalence of around 1.5 million. And each year, probably about 140,000. And that you can see, because there's 500,000 total deaths thought to be due to TB, around 1/3 of the TB deaths are probably CPA in India. So this is a numerically quite a big problem, and it's hidden in part under tuberculosis. Many years ago, we also estimated how many patients there might be with SAPS, which stands for severe asthma with fungal sensitization. And the data is not terribly good, but probably around 6.5 million. And with ABPA, which is allergic bronchopulmonary aspergillosis, probably just under 5 million. And when you look at that, those two entities occur in the 200 million adult asthmatics around the world. And there are probably quite a lot of cases in children as well, around 2 million probably affected, although the data for children is not very clear or strong. So what is this entity, chronic pulmonary aspergillosis? these are a pair of X-rays of unilateral TB, unilateral chronic pulmonary aspergillosis, and you can see that they're fairly similar. They're different, but they're fairly similar. And it would be very easy to mistake one for the other. And in centers where they haven't got sophisticated additional diagnoses, diagnostic tests, and also there's a lot of TB, you can see that a lot of patients with CPA may be diagnosed as TB. If you look at the similarities and differences between these entities, if you have fever and night sweats, that's more suggestive of TB, although they can occur in CPA, but they are more commonly found in TB. And if a CPA, if the cough is persistent for weeks and weeks and weeks, and a lot of hemoptysis, then that's more consistent with CPA. But cough, weight loss, fatigue, breathlessness, and a little bit of blood in the sputum occur with both these conditions, and so you can't really distinguish them. And radiologically, patients with lymphadenopathy in the chest or effusions are much more likely to be TB, whereas if you have an intracavitary fungal ball, that's very characteristic of CPA, but doesn't exclude TB. And then pleural thickening, paracavitary fibrosis, and solitary lesions are also what are found in CPA. And then you've got a number of other entities which are found in both conditions. So after you're cured of TB, you can get chronic pulmonary aspergillosis occurring a long time afterwards. So this small study of patients presenting with very severe hemoptysis from Brazil shows how late after TB they can present with CPA. And you can see that they're still presenting 35 years after they've been cured of TB, although the majority, about 40%, present in the first 2 to 3 years after they've been cured of TB. In this one small series, there are others, but not very many of this duration. So the symptoms of CPA, as I've mentioned, are cough, usually productive, shortness of breath, weight loss, tiredness, coughing up blood, and chest aches and discomfort. And then sometimes you have fever with or without night sweats, severe pain from a rib fracture, and additional chest infections. And many of these patients have other chest problems as well. So they've got COPD or asthma, or they've had a pneumothorax, or they're smokers or whatever. So there's a lot of other things that are common to these patients. And coughing up blood like this is very typical of CPA, and it's quite florid and quite remarkable. And sometimes you have some purulent sputum, as in the right-hand side, but often you just have blood, as in these examples. And one of the problems with CPA, and this is true for the early features of mycetoma as well, is many patients have no symptoms or very trivial symptoms. And so it's really a very quiet condition. It's easy to miss it as an entity. Now, one of the manifestations of CPA is something called a simple or single aspergilloma. And this young woman from Pakistan had previously had a diagnosis of TB. She presented with hemoptysis, but she was otherwise absolutely fine. She had positive aspergillus antibodies in her blood. And because this was an isolated lesion, she was able to go to surgery and have it removed. And particularly in a young woman, this is important because taking azoles is contraindicated in pregnancy. And so if this woman hadn't had any children at this stage, so putting her on long-term azole therapy was a real challenge in terms of managing her future ability to have kids. These fungal balls are really rather remarkable. They can be quite large in size. You can see the one on the left is from about 10.5 to 16.5, so it's about 6 centimeters across. And they're quite big, many of these. And the fungus grows inside the cavity, and then it comes off and sticks to the rest of the fungus inside the cavity. So you get a sort of constant process of of the regrowth of these fungal balls. And many of the patients, but not all of them, progress on therapy. So this woman had, from the Gujarat, had a diagnosis of TB. She'd been treated for TB. She then presented in '92 with more symptoms, and she declined surgery at that stage. Medical therapy was not really given in that era. And you can see progression over time, over 5 years, with her losing the whole of the left lung and the development of a very significant fungal ball. And if you look at the inside of the cavity, you can see fungus growing inside it on the surface of the cavity. And so in terms of therapy, if antifungals do get to the surface of the cavity, and they will get to the to this surface growth, there'll be less penetration probably into a large fungal ball, although the Japanese have measured that and in a couple of patients and found itraconazole inside a fungal ball. And this is an example where it looks like the patient's getting better because you've got a more black area around this fungal ball appearing. But in fact, if you look underneath that, in this area, you can see that this is actually progressing. And what's happened is that the cavity is actually grown in size, but the fungal ball is not. So it looks like there's more space and the fungal ball is smaller, but it's not. But you've also got progressive cavitation in underneath this fungal space. So it can be quite a tricky area. So the diagnosis of CPA is made on basically 3 elements. You've got a chest X-ray with the characteristic features. You've got some symptoms, although as I've said, some patients have very few symptoms. And then the key test is an Aspergillus IgG antibody test. And this is available in several different formats. This piece of work from Findra, who completed her PhD with me some years ago now, used the Siemens assay, but there are ELISA assays and there's a point of care assay as well. But it's the combination of these 3 things which give you a diagnosis. And so just having symptoms or just having a chest X-ray is not sufficient. We've also looked and just published a big study looking at individual patient data and outcome for mortality in chronic pulmonary aspergillosis. And you can see over a 5-year time frame that younger patients do much better. They have a 92% survival, whereas if you're over the age of 60, then you only have a 44% survival. And those with post-TB lung disease do reasonably well at 57% survival, which is better than those with interstitial lung disease, COPD or NTM disease. And also, when you look at the different forms of aspergillosis, subtypes, if you like, for CPA, you can see nodules and aspergilloma do pretty well, but subacute invasive chronic cavitary and chronic fibrosing all do not quite so well. And so there are different factors affecting outcome in these different patients. So that's the background. Treatment. So what are we trying to do when we treat these patients? So we have a group of patients who come who are really, really poorly, and they have lost a lot of weight. They can't breathe well. They're coughing up a lot of blood, and we're really trying to rescue those patients and prevent them dying. And so we usually give them IV therapy and follow that with oral therapy. We then have the largest group of patients who are somewhat ill. They're coughing, they're unwell, they've lost weight, they feel tired, sometimes they're very tired. And what we're trying to do there is improve their quality of life and also prevent them coughing up more blood. We're also interested in those patients in stopping the progression of fibrosis or scarring in the lung. We want to avoid the emergence of resistance, and we want to avoid antifungal toxicity. And in those with very few symptoms, you could say, well, why are you treating them? There's nothing to treat. But we know that this is usually a progressive disease. We don't know how to distinguish who's going to progress and who isn't. So we want to try and stop progressive destruction of the lung. And antifungal therapy, I think, does that, although it's a difficult thing to prove. We also, of course, in those group patients, don't want to get resistance emerging or antifungal toxicity. So the three oral agents that have been most used are itraconazole, voriconazole, and posaconazole. The usual dose is as for an invasive fungal infection, so 200 twice a day of itra, usually 200 twice a day of vori, and 400 of liquid twice a day, or 300 milligrams once a day of tablets for posaconazole. And the quality of evidence to support all those treatments is level 2. We don't have quite as much data on posaconazole, but it probably is as good as itraconazole and voriconazole. A lot of the patients with CPA are quite elderly, and voriconazole is not as well tolerated in older people, and also tends to accumulate. So we tend to use slightly lower dose in older folk. And also we worry about people from Japan, Korea, and northern China who may have maybe slow metabolizers of voriconazole. So this RCT in northern India and Chandigarh compared 12 months and 6 months of itraconazole, and you can see that you've got a 72% response rate in the 6-month group and an 88% response rate in the 12-month group. And when you look at the relapse-free survival after completion of therapy, you can see that the 12-month group had a much lower rate of relapse than the 6-month group. So probably this is a useful, giving longer therapy is a good thing to do. Now, another challenge with itraconazole is that there are quite a lot of generic formulations, and there's liquid versus capsules as well. So Sporanox on the right was the original preparation in liquid and capsule form, and you've got the Sandoz variety and I think a Glenmark variety on the left. And these drugs, although it's the same drug, they don't behave in quite the same way. So with generic itraconazole, the Sandoz variety, in a patient with ABPA, we switched that patient and the levels fell to 66% on the Sandoz itraconazole. And then when we put the patient back on Sporanox, the originator form, they rose back up again. Another patient with chronic pulmonary aspergillosis had a fall in 44%. And we had another patient with CCPA who also had a fall. And that last patient developed resistance to itraconazole, which is one of the downsides of having low levels of this drug. And a rather more sophisticated, larger study was done again in Chandigarh by the same chap who ran the randomized control study, looking at about nearly 200 patients on itraconazole with CPA. And you can see that the proportion of patients responding with having adequate levels was only about a third of patients on the generic drug, but more like 73% on the Sporanox itraconazole level. But there was no change in adverse events, interestingly. And when they looked at the preparation under the microscope, you can see that the originator preparation was very uniform and was clearly manufactured to a very high standard, whereas a couple of the generic forms had very variable sizes of particles, and that produced this sort of variability and obviously reduced bioavailability. And that graph, or that table from the same paper, shows the very big difference in response rates with low levels versus adequate levels. So this is probably ideal for mycetoma patients as well, because if itraconazole is made freely available, you don't know which variety it's going to be, and you don't know if you're going to have low levels or adequate levels. So itraconazole has some challenges in terms of therapy, and so in Manchester we always would monitor patients' blood levels with this drug. Okay, so Felix Bongerman, who's back in Uganda and works in Gulu, spent a year or so with me, and he did this big audit of 200 patients who were started on therapy in a single year, over 2 years, and he looked at those who were treatment naive, 140 patients, or those who were switched to something else. And one of the things that's interesting here, and the variety of drugs that were used were here. And one of the things that's interesting is how many patients had to change treatment or discontinue treatment. So only 40% of the patients stayed on the same therapy over a period of 12 months. 32% had to change therapy, usually because of toxicity, adverse events, but sometimes resistance. And about a third of the patients just couldn't take it at all. And this is a piece of work we did some years ago about itraconazole side effects. And we looked at all the different side effects that itraconazole can induce. And in our patient population, about 45% had some adverse event. And some of these were quite significant. So one, sleep disturbance was a problem. Paresthesia, peripheral neuropathy was another problem. Tremor was a problem. But there's also GI upset, peripheral edema, so ankle swelling, breathlessness, headaches. Some patients got hypertension. Only a few had abnormal liver tests, actually. We had hyperglycemia, taste disturbance, and some patients who lose their taste with itraconazole or other azoles don't get it back again, so it's a really very disabling problem. Few patients had menstrual disturbance, and we had some with adrenal suppression. Usually that's related to inhaled steroids, but an interaction with inhaled steroids, but it has been reported independently with both itraconazole and posaconazole as leading to a hypoadrenal state. So this is something, these are mostly Caucasian white patients, not completely, but mostly. So it would be very interesting to know whether you have the same side effect profile in your patients, and to what extent, how serious these side effects are, and how often it causes the patients to stop treatment. When you look at the probability of adverse events, they increased as the itraconazole concentration in the blood increased. So there was quite a strong relationship between increasing exposure and these side effects. So that's another reason for considering monitoring. So I've shown you low levels related to failure of therapy and generic forms. And here you have a problem with high levels leading to additional toxicity. So, monitoring is something that needs to be thought about. Now, prescribing of azoles generally needs to be done with care, because there are a lot of drug-drug interactions. And this is from this paper, which was published last year, I think in February. You can see the quite really a list of drugs here on the left, which really shouldn't be given at all with azoles. Rifampicin is one, because you have essentially undetectable levels, except unless you give much higher dose of posaconazole or fluconazole. Of course, fluconazole doesn't work for aspergillus, so it might be useful for candidiasis or cryptococcal disease, but not for aspergillosis. And then patients with epilepsy on phenytoin or carbamazepine are a challenge. Patients with MDR-TB, bedaquiline increases the risk of abnormal liver tests and QTc prolongation. And you've got a few others, ivabradine and others, which are a real issue. So the care here is important. in terms of prescribing and looking after these patients. And this a paper that we wrote includes a list of all the drug interactions, not listed one by one, but access to and then their numbers. And you can see that itraconazole, itraconazole, voriconazole have the highest number of severe drug interactions. And some of these are potentially lethal drug interactions. So it's really important to not have these and to consider them. And one of the things we do is to give our patients access to this database. So when another doctor wants to give them a medication, then the patients can look it up. So the other problem we face with long-term treatment is the development of resistance in aspergillosis, in Aspergillus fumigatus usually. And so this is an example of such a woman. This woman, originally from Malawi, she was on antiretroviral therapy. She previously had TB. She presented with hemoptysis, and she had these 2 large fungal balls in the lung. Her Aspergillus antibody, which was called the precipitins assay at that time, was high, 1 in 16. And there was a question about whether she could have surgery, but she would need a pneumonectomy, and there was a lot of normal lung around these fungal balls. So we elected to treat her medically, and she was treated with itraconazole. And so that was 2005, 2007. So 2 years later, her antiretroviral therapy is really working very well. Her CD4 count is up. She's done fine. She's got new hemoptysis, and her Aspergillus antibody test has risen. And when she had her scan done, you could see expansion of the inferior cavity, and you can see it on the plain chest X-ray here, that next to the hilum, on the left of the X-ray, the patient's right, you can see this fungal ball is actually more prominent than it was before. And the isolate that was grown from the sputum showed frank resistance to itraconazole, but fortunately it was susceptible to voriconazole. It was also resistant to posaconazole as well. So she was switched to voriconazole and actually responded to therapy with that. So just going back to this survey that Felix Bongerman did, over a period of a year, we had 13 patients with demonstrable itraconazole resistance, 8.6%, and 2 patients who developed voriconazole resistance, 4.7%. And so this is another risk of long-term azoles, is the emergence of resistance. Now, one of the things that might avoid that is if a drug was suicidal and killed the fungus. And this graphic shows the difference between MIC, which is an inhibitory value, and an MFC, which is a cidal value. And you can see that using the red line as your marker for drug concentration, which would be approximately what you might get in the blood, you can see that for isavuconazole, which is BAL4815, you can see about 55% of the isolates are killed at that concentration. About just under 50% are killed with itraconazole, and about 75% are killed with voriconazole at that concentration. So we don't normally measure this fungicidal concentration, but I think it may be relevant to the emergence of resistance in these patients. And it's something that I think would be an interesting thing to follow up on. And it may be relevant for mycetoma and other chronic fungal infections as well. So in conclusion, itraconazole remains the initial treatment for CPA, but you can see that there are challenges with it. Outcomes are better with longer treatment. Low concentrations are linked to therapeutic failure. High concentrations are linked to more adverse events. Generic formulations associated with lower exposures and blood levels. Multiple drug-drug interactions, and some of these are dangerous, and others are linked to poor outcomes or toxicity. Azole resistance occurs on therapy and is relatively frequent. And there are some parallels, I think, with the treatment of mycetoma. So for those of you who haven't found it yet or don't know about it, fungaleducation.org is a website that we run with a lot of information about multiple different fungi. We have not done very much on mycetoma, not for any particular reason, except that it's complex and it's pretty uncommon in many parts of the world. And we have wanted to focus on the more common infections with this website. And we also run the aspergillosis website, which is a very good resource with images, case studies, all the literature on aspergillus, going back to the historical articles, and lots of summary articles, the drug-drug interaction database, and many other things. With that, I will stop. I'm happy to take any questions if there are any, and otherwise, hopefully that was of value to you.
Well, thank you so much, Professor David, for this amazing presentation and for taking us through this. Now the floor is open for questions. Professor Fahal, if you would like to comment.
Thank you very much, David, for this nice and elegant presentation on a problem which is very difficult to treat. The patients are suffering a lot from the disease and from the socio-economic consequences of this, just like mycetoma. In mycetoma, most of the patients are young adults. They are healthy. Comorbidity are not so common. The immune status of this patient is almost within normal. Still, we find difficulties and challenges in dealing with these patients, especially with antifungal treatment available for us.
Yeah, sure.
And then you can see our patients with aspergillosis. Most of them are having either tuberculosis in the past, they have a cavitation, they have predisposing factor, immunosuppression, and still you can find the treatment with itraconazole is not so brilliant as expected to have this. What is the reason for that, please?
Yes, I don't know the reason for it, but in fact, we don't really know why some patients fail therapy. I think one of the reasons is low exposures. We think there's a genetic element to CPA, and so possibly they have bad set of genes and they can't mount any response to kill the fungus. And we did find that those with the low antibody titers respond worse than those with very high antibody titers. Maybe the immune response may be a part of this overall response to things.
I see that Lemise has a raised hand. Yes, Lemise.
Hello, thank you, Professor, for this amazing session. And I was wondering, did you look into, because we know that for basically all drugs, there are fast metabolizers and slow metabolizers. So do you have any idea of the effect of the metabolism ability of a patient on how they respond to itraconazole or any azoles? And could this be like a reason for why the response to itraconazole in mycetoma is so variable?
Yeah, I don't think we do know the answer to that. I mean, there may be frank resistance. That's one problem. I think drug penetration, particularly into bone, may be not good enough. Low exposures of drugs. But I think we don't really understand the reason for patients failing therapy, I think. At least I don't understand it.
Prof, I see Professor Fahal has a raised hand. Yes, Prof.
Once again, David, Usually at the Mycetoma Center, we don't measure the resistance to itraconazole. One, because what you see in the vitro is not what you see in vivo. So if you have some idea about what's happening in vitro, it not necessarily will be seen in patients with mycetoma at this site. Do you think it will be um, a good idea in the future to study the resistance to itraconazole?
Yeah, I think the first thing to do would be to try and measure blood levels, because that's something you can fix quite easily. Resistance is a much harder thing to fix. You'd probably want to revert to intravenous amphotericin if you had a resistant mycetoma, I think. But that's, that's pretty drastic because it's IV therapy and expensive and complex. So I don't know the answer to your question. I think I do think that thinking about resistance emergence on therapy is something that we need to address with all these chronic fungal infections.
Okay, Prof, I just have a small question, is that you've mentioned that for severely ill patients, you give a combination of intravenous antifungals followed by oral therapy. So what are the IV antifungals that are drugs of choice?
So obviously we start with the azoles. If you have to switch to IV because the patient's failing therapy or they develop resistance, then we use either liposomal amphotericin B, and historically we have given that daily at 3 milligrams per kilogram. I think there are arguments giving higher doses less frequently, but that hasn't been done much. And then the other drug we use is mycofungin, which is quite active against aspergillus and candida, but I don't think it's active against the mycetoma organisms. And we give that at a standard dose 6 times a week, and we've given that for like 3 weeks, or we've given it for extended periods of time. That's, I think, how I would think about it. The new drugs that are coming out may be valuable, but we don't know the answer to that for this disease. There are also going to be inhaled antifungals coming. So there's a company doing inhaled itraconazole, another one doing an inhaled other azole, which is a new azole. And so for patients with fungal asthma, that may be a way to go rather than giving them oral therapy. And that may avoid some of the toxicity of systemic therapy. So I think those are the, I think that's how I'd approach the alternatives for therapy.
Okay, thank you, Prof, for this. Lamise, I see that you have a raised hand.
Yeah, thank you. So Professor, I keep saying that, for example, when it comes to discovering new antifungals, like there are really very few classes of available antifungals in general, if you compare it to antibacterials and, antiparasitics and so on. So I keep wondering, like, why is that? Why is there no, like, a lot of new other classes of compounds that are being discovered, given the fact that almost one of the biggest problems that we have with fungal infection is that they're really difficult to get rid of. So there is a big need of discovering new drugs, but you really don't see that if you compare it to the antibacterials and the other types of drugs.
Yes, I think your points are well made, and I don't quite know what the right approach to this is personally, but I think, one of the things that you have studied, of course, is ravuconazole, And that has the merit of being given once a day, and it may be that you get less resistance with it. You may have much less blood level variation with it. But you also had to give treatment for 6 months to start to see improvement. With CPA, we tend to get improvement earlier in 3 to 6 months. So there is a difference in the way that the body responds to these drugs. But I'm not sure that I know quite the answer to your question, actually. I think there's much more work to be done in the area.
Professor Fahal?
Yeah, yeah, we at the Mycetoma Center we used to treat some patients with voroconazole, but our experience is not so good. It is very toxic drug with a lot of side effects, and we have to stop the treatment for many of the patients. Secondly, it's not available because it's expensive drug. What is your experience with voroconazole, please?
Yeah, so I think the side effect profile of itraconazole and voriconazole are quite different. So sometimes you have a patient that can take itra but not vori, or vice versa. So we do use them interchangeably. But there's also a group of patients that can't take either of them. And then we've tried posaconazole and they can't take that either. So once you've not been able to take itra and vori, only a third of the patients can then take posaconazole. So there may be a sort of general inability to take azoles in terms of adverse events. The voriconazole issue is probably partly about exposure. So I think if you were to do this again, it would be really helpful to have some blood levels. It's a much shorter half-life than itraconazole. So the levels go up and then they go down again quite quickly in adults, and even more so in children. So it's given twice a day, but the typical half-life is 6 hours or 8 hours in adults. And my impression of filamentous fungi is that we need to keep the drug concentration in the blood and tissues above the minimum inhibitory concentration all the time. So there's a lot more variation with voriconazole. There is something called a post-antibiotic or post-antifungal effect, which has some carryover for 2 or 3 hours, but I'm not sure it's enough to compensate with this dips in exposure with vori. So another thing to consider is 3 times a day, but that's very burdensome for the patients. But it might be that would give you a better overall outcome. So I think describing the side effect profile in your country would be a very helpful thing to do, because I've shown you what we have in white people in Northern Europe, but I think there'll be different side effect profiles in Sudan and maybe in India and China and Southeast Asia and Brazil and so on. So. There's a question online from Bruna. She's written, thanks so much to participate. How much to differentiate colonization and infection when we analyze fungal culture? We have many TB patients and sometimes it's difficult to start itraconazole. So the sensitivity of sputum culture for CPA is about 30 to 40%. The sensitivity goes up if you take high volume culture, if you do a fungal culture instead of a bacterial culture, and if you do multiple cultures. So you can sometimes increase your yield with these 3 strategies. The patients in whom I think are most likely to have CPA are 2 groups. One of them is the patients with possible TB relapse. So they've finished their TB treatment and they come back and with new symptoms, and about 50% of those patients will have CPA. It was 57%, I think, in India, about 50 in Vietnam, and 50 in Ghana. So that's an issue, a relapse. And then the other group is the patients who have unproven TB. So you've sent sputum off to the lab, you've done a gene expert or sputum culture or microscopy, and they're negative. And that group of patients, probably 20 to 30% of those patients have CPA. And in Brazil, of course, you have histoplasmosis, you have paracoccidioidomycosis, and a little bit of coccidioidomycosis. So there's a differential diagnosis, which isn't just aspergillosis, but other things as well. And so those things, I think, need to be taken into consideration in your analysis of these patients. The key here is antibody testing, aspergillus antibody testing, or histoplasma antibody testing, or paracocci antibody testing, or cocci antibody testing. That's where you're going to be able to really start to sort out the cases more than just doing cultures, I think.
Professor Fahal,
Yeah.
are you trying to say something or?
No, thank you very much.
Okay. Well, no, the floor is open for questions. If you have a question, you can just write it down in the chat or you can raise a hand. Professor David, do you think that experiencing the adverse events with itraconazole, does the being slow or fast metabolizers has a role on this? Because the adverse events that you've seen with your study, we didn't see much of them actually. So
Yeah.
is there a difference between being slow or fast metabolizers?
It may well be, that may well be the case, yes. There are a few CYP3A4 gene genotypes which are fast or slow metabolizers, but not many people have studied that carefully. But that's, I think, where drug level monitoring might be helpful to know what actually the exposure is. And we used to do bioassay measurements, but you can do HPLC or you can do mass spec measurements. So there's 3 different ways of determining the blood levels. Your supposition about fast or slow metabolizers, I think, is probably right, but we don't have the data to be confident about the frequency of that in different populations.
Okay, that's great. Yes, Professor Fahal?
Yeah, David, we noticed that our patient with mycetoma on long-term itraconazole, rarely they have a liver affection.
Mm-hmm.
Some of them, they have just temporary raised enzymes, and very few, they develop some increased level of bilirubin. And rarely you see they develop a frank clinical jaundice in these patients.
Yeah.
Uh,
I think
yeah.
that's right. I think it's actually, once you get past the first 3 months, liver abnormalities are really quite rare. And we tend not to do liver tests after 6 months on therapy, more than twice a year or something like that. We do quite a lot of testing in the first 3 months of therapy, and then we reduce the frequency of that. So I agree with you. I think it is pretty uncommon.
Yeah. Okay.
My screen has gone green. I don't know if that's me or the camera, but anyway.
So, Professor David, would you like to add anything?
No, just thank you for the opportunity to speak to you all today, and keep up the good work, keeping mycetoma and fungal infections in the front of mind across the world, because it's very easy for people to forget about these infections, I think.
Okay, and would you mind just sharing your presentation? We will be uploading it on the club's page on the Mycetoma Research Center's website.
Sure.
If you don't mind.
Yeah, that's fine. No problem. Yeah.
Okay, and this session is actually recorded, and it will be uploaded on the YouTube channel of also the Mycetoma Research Center's YouTube channel. It will be uploaded there. So, Professor Fahad, would you like to add anything before we wrap up?
No, thank you very much. I guess I would like once again to express my sincere thanks to David for this nice presentation. And education, actually, it was very much educational about this rare infection here in Sudan, aspergillosis. And we have to be aware of this disease because a lot of people, they miss it as tuberculosis. Thank you very much, David, for this presentation, and we're looking forward for more collaboration and contribution to Mycetoma Research Club. Thank you very much.
Okay, all the best. All right, thank you very much.
Okay, bye-bye. Thank you.
I
Bye.
would like to thank you all for joining us today until we meet back again. Thank you, Professor David, for joining us. Thank you, everyone.
Okay, bye.
Bye-bye.